and Health Select Committee. I am Councillor Knight, Chair of the committee, and I will be chairing tonight's meeting. This event will be recorded and will be available to members of the public and media to watch following the meeting. Now I'd like to welcome all of you to the Council Chamber Committee Room at Kensington Town Hall. Before we proceed with this meeting, I would ask members of the committee to please make sure your mobile phones are silent and switched off. I think it would be appropriate for us to start with 72 seconds silent to remember those who lost their lives in the Grenfell tragedy.
Thank you.
We start with A1 apologies for absence. Apologies of absence have been received from Councillor Dr. Mona Ahmed, Councillor Ansar, and Councillor Gerard Hargreaves, and our co-opted member Cleo Drew. Apologies for lateness have also been received by Councillor Whedon Sands, who should be here shortly. And this is probably an appropriate time to say we've also got Councillor Mary Will at the table, as she's particularly interested in some of the papers. Moving on to declarations of interest. Does any member have an interest to declare? Yeah. And then agenda item 3, minutes of the meeting held on the 20th of May 2024. The minutes of the previous meeting have been circulated. Does the committee agree to sign the minutes as a correct record? Yeah. Moving on to agenda item 4, community diagnostics centres in North London. This report sets out an update on the development of community diagnostic centres in North West London. Members of the Select Committee were invited to consider the report to the NHS as attached in Appendix A and decide whether it wishes to make recommendations to the NHS partners after considerations of evidence and findings at the meeting. I'd like to welcome Damien Ritchie from Imperial College Healthcare NHS Trust and Dr. Philip Lund from London North West University Healthcare NHS Trust to the meeting, and thank them very much for joining us. I'd like to invite you to give a short introduction on the report with the council session. Thank you.
Lovely, thank you for having us back, Council. Dr. Lipman and I came here in 2022. Late 2022, at which point we had, as a programme, just had approval of our strategy and our business cases. So we set out to establish 3 community diagnostic centres across North West London, particularly situated around trying to target communities. And we identified for our programme 2 areas in particular that we were clustered deprivation we wanted to focus on. In asking us to come back forward today, obviously we're able to give you an update around the implementation of those. So at that point, we sort of exited the planning and business case approval. It was then really about pivoting towards the implementation programme for the 3 centres. We have now opened 2 of the 3 CDCs, with the third one to follow very shortly. So that started with the Wilson CDC, which is in an existing building, Wilson Centre for Health and Care. We opened that service back in June 2023, and that provides a range of services from an imaging perspective. We have X-ray and ultrasound services, and we also have cardiology, respiratory physiology services, and ultimately on that site. So that one's now been running for just over 1 year. More recently, we've just opened up a brand new facility, a new building in Wembley, which is for us quite novel, which is out of hospital MRI and CT scanning. So across North West London, all of our NHS facilities are traditionally based having those services within a hospital setting. And this is now the first time we have those services available outside of the hospital setting within the NHS. So we have 2 MRI and 2 CT scanners open at Wembley, and that's been open since the 15th of January. So now just approaching 6 months since the launch of that service, and we have the final 3, please to say, going live for all of the services on the 12th of August. So the Ealing CDC will provide the same set of diagnostic services as the Wilson and Wembley CDCs combined, all under one umbrella of what's referred to as a standard set of hubs followed by NHS. We've broken down in the reports, and you can see the number of tests that we've delivered in quantum for each of the CDCs since we've opened. So if we go back to the appendix at the back, you can see for each different type of test for each CDC, the volumes that we have provided through that. And we've also tried to bring out for yourselves in particular around for the Royal Borough of Kensington Chelsea, some data around actually what that means for some of your residents as well. So you can see in the pack where we've included a breakdown of attendance data by borough. So you can see how many of those patients are from your borough in particular. And also looking at, although apologies, we just have it in here for Wembley, we can also include that data for Wilson post on meeting. But also looking at the deprivation index data for the patients who are attending for Wembley, so that you can see the range of attendances that we are getting. So I think that's probably the sort of highlights to bring out from the reports, and I'm very happy to open up and take any questions you may have.
Thank you very much, and thank you so much for coming. And it's really good to hear an update. I think we were here in November 2022, so it feels like a lot has happened since then. I think my first question is just, and I appreciate you are still yet to open Ealing, which I think will be your largest.
It will,
Yeah.
yes. Yeah.
But it was just how, firstly, in terms of the 19,000 appointments you've delivered this year, you plan to, I think, get up to your additional 180,000 at new state. So how that's going to be stepped up quite so significantly in the next year, just to understand that would be great.
Yeah, sure. So I can come in on that, and feel free to support me on it as well. So so each of the biggest uplift in capacity will come when the Ealing CDC opens. So that will be when we've got quite a significant uplift. So we will have an awful lot of capacity going live in the coming month across a range of services. So particularly from an imaging radiology perspective, we've got 2 empty MRI CT scanners sitting there waiting for use. So we've got 4 ultrasound scanners waiting for use. We've got a DEXA scanner sitting there and an X-ray machine as well. So we've got quite significant plans. We've got an awful lot of staff recruited and trained up for the use of those different bits of equipment. Likewise, also from a cardiology or respiratory basis, we've also got the majority of the staff in post, and the final 1 or 2 posts being recruited into for those services in particular. We do have and this is so the 180,000 number is for this financial year. So going back to our strategy from 2022, and our business case is what we have as a year-on-year uplift. And that really reflects 2 things. So that reflects the need to increase the services incrementally in line with demand. So we have national projections, but also local projections around the uplift for certain modalities. So we have intelligence about how much we're expecting each service to grow for the different modalities. But also really recognising the fact that we have to get these services open and grow the workforce, and that's really critical as well. So we have for each of the CDCs, it varies for each of them as to when exactly, but either in the back end of this calendar year or in the start of 2025, we have an uplift against certain services to increase the operating hours essentially for that. But that has to go in line with developing, training, recruiting more staff to fill those services.
And just before I go to my colleagues on the staffing side of things, I know that was a concern generally about across the country for CDCs regarding staffing of CDCs. And that's not a concern of yours at the moment as to recruiting and maintaining that we are able to provide these services with the right amount of staff.
I'm going to say it's not a concern, but I'm going to caveat it if you don't mind. So I'm going to say it's not a concern in the same way it was when we did the planning and strategy piece. So it was you'll recollect it was our biggest risk, frankly, to the program at that point. There's been quite a lot of work that's been undertaken nationally through the program from NHS England to increase the pipeline of staff coming through, so new recruits in. We've also had quite a lot of success in attracting staff from the private sector, so the CDCs are actually quite attractive places for staff to work. And there's also been quite a lot of effort going into, for example, international recruitment, and we still have more work going with international recruitment actually as well to further bolster our workforce. So I do want to keep the caveats in there because it is still a risk. So there is always going to be a risk with this because that workforce has to keep on incrementally growing in order for us to meet demand. But the big risk that we had at the start of the programme has been significantly mitigated through the success that we've had so far. If I take Ealing, for example, where Phil will be leading the development of the Ealing CDC, when that goes live in the next month, we've got the majority of the staff recruited in there, ready to go, train, ready. They want to get into see patients.
I would still say that there is slight hesitancy with that, in that we haven't managed to fill all the posts, but we've put in place a lot of mitigations for that, and we've looked at a number of opportunities that sort of developed into more national driven directives, given the number of CDCs nationally that have all come out, they've all had the same sort of issues. And so through that, we've actually been successful in the way that we've managed to fill those posts. So cautious of concern.
Okay, good evening. Thank you for this very informative report. I was just curious to know what measures will be in place to ensure that plans will be reduced inequality and improve access to those who need it the most.
Sure. So I think this comes back to the heart of the programme, really. So what we tried to do at the very start of our approach to delivering this in North West London was there was actually an opportunity to set up what they referred to as early adopter CDCs, and that goes back to I'll say the financial year of 2020, 2021. We took a decision which seemed a bit uncomfortable at the time, not to go ahead and deliver a CDC in that year, but actually to do the preparatory work that we needed to do to have a look at population health data. So when we started our programme in North West London, we actually did a huge amount of work looking at North West London population health data. We looked at a range of diagnostic data as part of that. And what we tried to identify was actually where the greatest health need was, and in particular where the greatest areas. What it boiled down to, when you looked at lots of different metrics, pretty much consistently it always came back to deprivation, and that was the consistent theme that we settled upon. As part of that, and you'll from our previous presentation here, there's a map that I usually use, which sort of highlights the areas of high deprivation across North West London. Our access points and our travel considerations, both in terms of public transport and private car use, were deliberately targeted around trying to make these centres accessible to our most deprived communities across North West London. The other piece, which I think is really critical to that, is trying to increase the opening hours as well. So rather than just the traditional Monday to Friday sort of 9 to 5 model, trying to look at how we can actually increase the access points for across the week, so that actually patients can choose to come in at different times that aren't necessarily in what may be sort of traditional working hours for residents. So, for example, over at Wembley, at the moment we're currently open 7 days a week for our, and in fact we have been since we opened. We've been open 7 days a week for our MRI service. So we have 2 MRI scanners there that are open 8 a.m. till 8 p.m. And for example, we're just having a conversation this morning with the lead for that area about what more we can do. So we're working on a proposal about what that may look like. So we're getting a lot of patient feedback actually about could we open from earlier. So we're just about to start to survey that and get a better idea of what that looks like. But for example, I don't commit to anything here because we need to work it through, but it could be 6 a.m. till 10 p.m., for example, 7 days a week. But we have to understand what that patient demand looks like in terms of when it's accessible and when patients want to come for their tests.
Thank you. Chair, is there a little question about your
Yeah,
drawing?
no, go for it.
And also, I'd just like to know, how will you be evaluating the impact of the CDC on the population? How would you find out?
Yes, so the population health exercise that we undertook, so it goes back to what we need to do is we need to revisit that piece of work. And so we started having conversations actually this week across the region around what would a further CDC wave look like if that's something that materialises. Obviously, we need to wait and see what comes in terms of national developments around that, but there's a potential that we are anticipating there may be potentially a further expansion of diagnostic facilities. So that's something that we are now trying to think through. The one in particular, the one piece that I was really keen to, as part of that discussion, keen to think about is revisiting that population health analysis piece. So we need to understand the impact of the interventions that we put into place. And we need to understand where the areas of demand still are, and how we try to then access and target those communities in particular.
I have a question. So once you go into a CDC and you get your diagnostic or you get your CT scan, which you probably can't read yourself as a patient, what happens next? How do you actually link that patient back to the system? And how do you measure that the CDC intervention was actually speeding up the treatment process?
Yeah, so in some areas, we've taken it in North West London to link each CDC to a particular NHS trust. So in this case, the Wembley and Walsall CDCs are linked to Imperial, and the Ealing CDC linked to London North West. Mainly because in terms of things like governance, quality control, and those sorts of reassurances that you want, it's much easier to provide that within an existing framework that already has those high values. And so the aim is basically, so a patient comes in, or they get a referral that comes into the CDC, that then gets processed through normal methods. The patient comes in, gets a scan, it then goes within the radiology group where they report it, and then that then gets sent back to the referrer. The patient does get a report, but that's sort of staggered for clinical reasons. So it's just like a normal process, much like as if you were to attend hospital or radiology.
And do you see an increase in terms of treatment? I mean, do you see a faster treatment process? Do you see a recovery being, like, do we have measurements to compare with patients who go to CDC and those who, how do we actually assess that?
Yeah, so there's lots of different things lots of different waiting times data that we assess as part of that, and there's a lot of variation for the different services. Probably if we looked at some of the sort of radiology services, for example, that Philip Lung works in, something like CT services, for example, in particular, we've been able to make quite significant inroads in terms of reducing waiting times. So the way that works primarily is that actually, although we're increasing our case mix week by week and month by month, so we're increasingly getting the team are getting more comfortable with doing more and more out of hospital actually, where it's clinically appropriate to do so. But actually, essentially, what we're in a position to do through the CDCs is to release a lot of the patients who do not need to necessarily be scanned within a hospital setting, and scan those quicker, sooner within the CDC setting. So, for example, if a referral came through for a CT patient who was suitable for a CDC, we would have capacity to be able to get them in for next week. Whereas if you were looking at a hospital setting, it's more likely to be 5 or 6 weeks, for example. And the aim and ambition behind that is to then alleviate pressure on the hospitals to allow them to actually scan the patients they need to. So whether that be from patients who are already inpatients or emergency care, or there are patients who, acuity-wise or complexity of the scan, they need to be done in a hospital setting. So that's sort of the mechanism by which we manage it. Yeah.
Yes, I'm building on what Stephanie said. You know, in the pipeline or pathway, whatever you want to call it, this removes the blockage. I can see that. That's very clear. But once you ramp up to 180,000, you're going to pick up quite a lot of disease in there, and then you're going to want to refer that on to the specialists. Of how are they suddenly going to have capacity to deal with this extra wave of diagnosed patients? That was my sort of first question. And the other thing I wanted to ask about was your operating hours. Obviously, you're sweating the MRI. That's your most expensive asset. So that's why you're doing 8 till 8. I get that. And similarly, CT scan, second most expensive, Monday to Saturday. But the rest of it looks pretty traditional Monday to Friday opening hours in these. And you alluded to the fact that, you know, for working people, that's not always, you know, GPs are increasingly open in later hours. So it's a little bit disappointing to see a lack of ambition there on the opening hours for the non-capital intensive bits of diagnosis. But mostly I'm interested in the pressure that's going to be pushed on to the hospitals now and this increased rate of diagnosis and how you're going to cope with it.
So what I would say is at the moment, we're not the clinical groups, GPs and also hospital doctors will generate a certain value, a certain amount of demand. At the moment, we've not increased that demand, but it sits within a waiting list. So what we're doing with the CDCs is to expand our capacity so that we're able to reduce that waiting list and also harmonise it amongst North West London. So we're trying to reduce variations amongst population within the whole area. But at the moment, we're not doing things to drive up demand. So we're not getting clinicians to request more things. So they'll still be seeing the same volume. It will just be done a little bit quicker. It may be that later on that it may drive delays later on. But at the moment, we feel that it's better to remove the roadblock and then see how that eases through later on, because we're not sure with all of the different
logic say that if you're doing 180,000 extra tests than you were doing, you know that there's out of a population X amount of percent of those are going to throw up disease that needs onward treatment that wouldn't have been diagnosed that year and could have waited. So are you not just moving the blockage further along the pathway? That's my fundamental question. I think you're saying no, but I'm not quite reassured yet.
So in terms of the numbers that do end up with unproliferation cancer, right? Usually that number is around 3 to 4% mark. So we've taken the approach that, you know, yes, that 3 to 4% that doing what we treated earlier may add a pressure on the system.
It's about 5,000, 6,000 patients or something.
Only 5% will then get that benefit immediately. It is a difficult situation. I mean, with regards to the NHS and how strained it is at the moment, that is difficult. But we felt that it is more appropriate to do what we can where we can, and especially from a deprivation point of view, a lot of these patients never get through to see anyone, mainly because there's nowhere near them that they can get to easily. And so again, part of the driver of this is to have these areas where patients can go there and not did not attend, for example, where you get multiple patients who are similar to that. Plus, the flip side is, touch wood, we've got maybe the worst of COVID, but as David said, having something like a centre, it's attached to an emergency centre, would allow us, should there be a wave, since 2020, for us to be able to continue to work despite that. Whereas, during that first wave, we saw that we had to shut everything down because we weren't able to having cross flows with inpatients who had COVID with outpatients, just caused us a lot of cross contamination, so to speak. So we started looking at options to try and avoid that.
So I think my concern would be that somehow that this increased moving the unblockage along is monitored, what effect it has on the wider system, and also perhaps a bit longer opening hours for the.
We've just noted that down in the book. I was just actually gonna, don't know who's just raised this before Roberta said quickly, but I know we brought this up in previous meetings with Joss, considering travel with our residents, because we have two of the most deprived wards in central London, and obviously initially raised concern as to the locations of the CDCs. So particularly from North Kensington, where those two wards are, I was looking up today on City Mapper, the different routes, and they are complicated travel bus routes with numerous different changes. So I just want to understand now the CDCs are operating, how you're supporting residents who might struggle to get on two different buses or numerous different kind of big walking loops in between, or do not own a car, to access the CDCs, and if there is a sort of in place for that.
Yeah, I'm happy to comment on that. So patients get a choice ultimately. So patients are given the option to attend for whichever CDC we're talking about. They get the option to come to the CDC, and the trade-off and the benefit of patients who do come to a CDC if they can get their scan, whatever that may be, sooner.
Mm-hmm.
If a patient says, actually, no, I want to go to my local hospital, and that could be for many different reasons. Travel may be for one of those reasons. Patients are they're absolutely entitled to do that, and they are given that choice and that option. So I think that's a really important point to make first, because we don't force patients to go to a CDC. We give them the choice, and we explain the benefits to them. What we do see, and actually it was interesting in preparing this for coming here, actually, is we do see a lot of patients who are willing to travel.
Mm-hmm.
And you can see from the numbers in here for this report, quite a lot of patients from this borough who do choose to travel to both of the CDC that are currently open. Obviously, we won't yet know the impacts around Ealing until that goes live for the next month. But patients are surprisingly willing and able, it's our experience, to travel.
Yeah.
If not, then they still have the other routes available to them for existing pathways and existing areas to come in for their scans. So
there's not a sort of travel support system. I'm just, when you say that, I do appreciate you might choose your local hospital.
Yeah.
And as someone who has many regular MRI scans, when I try and choose Hammersmith, for example, rather than somewhere else, eating X, Y, Z, I get told it's in 15 weeks rather than. So I'm just conscious of the fact we're talking about deprived communities who we want to give their access to health, which these are about. But if someone's choosing their closer location, that feels like a significant compromise.
So one thing I would say is it does equalise a bit of access, because we've got to bear in mind we have lots of different centres within North West London. And so the idea is these CDCs will increase capacity across the region. And so, for example, if we're seeing high waves in Hammersmith, what will happen is that we will then offer those patients the option of the CDC. And those then go away, and so you should find your waste drop down. And so over time, it sort of gets a bit better. Plus, different regions will have multiple CDCs, and that should have an increasing effect over time. But if you're talking about patients who, for example, can't get on a bus or have to, then there are patient transport options for them. So, if they just because of disability or, whatever reason, there are other options, but they exist.
Okay, probably just one other thing, and that's really helpful. I'm not the expert on this, but this did come up relatively recently. And patients who are on certain types of benefits can also think back expenses as well. So that is something that we encountered actually very recently for Wembley. It's something we already do on the hospital sites, and it's something that we're making sure is accessible in exactly the same way for patients. So that's an example of where they can do that. It's not available to everybody, but that is available for residents who are on different types of benefits.
Well, just very quickly, just ask a query on that, if that's okay, Madam Chairman. How long does that whole system take in terms of them getting refunded? Is that a quick process where if they pay, they'll get the money back quickly, or is that something that we see?
Cashier, it's physical money that they hold. It's something that they have to fill in the form whilst they're there, but they can get.
And we get it back immediately.
Yeah, so it's cash. It's physical cash that's held. Not much, but physical cash that's held within a safe within the facility.
So thank you.
Do you have it?
I do. I think it's very interesting. I mean, you touched on deprivation as a way of, inclusive and equal. So it'll be very interesting to get a breakdown of which wards in RBKC residents will access your service the most. Is that possible?
At a ward level, as opposed to borough level, services. It's something we can take away, and see. It's not something that
I was going to ask that too, as well as Williston. But if you could look into that would.
Yeah, sure. Sorry, we obviously look at this at North West London level, and then we break it down by borough, but we can see if it's possible to break that down further.
Yeah, thank you.
Any other further questions on this one? My last question, just to is when you said potential of new CDC sites. Do you think, I know this model was started by the fact we might be having centres on the high street and away from medical environments. Do you think there's any to sort of create less of, what the right word is?
I think it all depends. It all depends on what, frankly, what is committed to through future spending reviews, and it will depend on the conditions and implementation guidance that's issued with that. So whether we are starting to think, because that's prudent for us to do so, and that's what I'm saying. I want to revisit some of that earlier work we did at the start of our program around population health, and try to understand what that looks like now. But in terms of scale, locations, types of services that we offer, it really will depend on investment and what is available for that.
Thank you very much. And I was just going to ask, firstly, I think one recommendation would be, from the committee, would be to continue to monitor RBKC residents' use of the community diagnostic centres, particularly in the most deprived wards, and address any issues of accessibility they may face. And then on top of that, as Nari said, to explore the feasibility of extended opening hours at CDCs and improve patients' access. And then you go another one you can.
In fact, all the range of diagnostics, not just CPCs. And the other thing was monitoring the impact further down the pipeline or path. I think everything has to be a pathway in the NHS. So further down the pathway, the impact of maybe 6,000 or 7,000 extra diagnoses of things like cancer on the facilities further down.
One thing I just want to mention, we had a patient's experience who comes to patients, and one of the findings that came out was that they really appreciated the fact that it was a separate building to the main hospital, and that they weren't treated as patients who were ill, so to speak. And that every single patient like that as a positive. So there are a lot of other additional positive benefits for patients who receive, not just deprivation of their obviously aspects.
Thank you. Thank you both for coming so much. It was great to see where you guys have got to. And I was keen to. Thank you. Moving on to agenda item 5, Grenfell Joint Strategic Needs Assessment. This report provides information about the refresh of the original 2018 shared data recovery joint strategic needs assessment. The committee are asked to consider how recommendations set out in the JSNA being implemented most effectively by a local authority and its partners. Attending, we have Anna Raleigh, Dr. Andrew Steeden, Councillor Josh Rendell. Ask Anna and Dr. Steeden to introduce this report.
Thank you very much, Councillor.
Anna, there we've got Anna, Andrew and Naomi joining online. Thank you.
Okay, so if I open Andrew and then I hand over to you. First of all, I'm really pleased to be joined by my colleagues, Muskan Parana and also Alicia Williams, who's been the key author of this report and programme managed the work that's taken place in the last 18 months. This document is a refresh of the 2018 Grenfell JSNA. And what we've looked to do is to develop a single evidence piece that brings together in one place the range of work that has taken place to understand health and wellbeing needs of the population. So that includes a health profile of the North Kensington population, and very specifically the Notting Dale ward for part of that as well. It includes a summary of the population health monitoring interventions and services which take place specifically for that population. It also includes quite extensive community engagement that's taken place over the last 18 months with a range of stakeholders from the voluntary and community sector as well as local residents. Alongside that as well, what we've looked to do as part of that is to summarise some of the environmental monitoring that has taken place, for example, with soil investigations, but also the ongoing air quality monitoring that continues to build up the baseline of information in the North Kensington area. So out of that work, I guess in summary, we would say there are pre-existing health conditions in the area of North Kensington that predate the tragedy. So what we would look to do is to understand health and wellbeing need against that backdrop. Amongst the local community, concerns about respiratory health, about cancers and long-term conditions remain. And also mental and emotional wellbeing needs continue to be high and ongoing within that population. The feedback from the local community has very much been that more work around ownership, accountability and service delivery is important. Within the context of that, community-led approaches to recovery, where we're working alongside, listening very much to what local residents are telling us and shaping services with them and being community-led in how we respond. I would also say that the Grenfell Pacific services can only do so much to address health and wellbeing needs. They also need to be seen in the context of the wider health and wellbeing board strategy and wider council policies and strategies around economics, housing, etc. But that again play an important role in improving the health and well-being of the population. We have 3 sets of recommendations. The 3 sets of recommendations are for the distinct needs of survivors and bereaved, also for the immediate population and those in the vicinity of the tower who continue to be affected by the impact of tragedy as they go back to everyday lives, and then the wider New Kensington population, particularly in the context of that wider backdrop of ongoing deprivation within that population. So this is a joint piece with our colleagues in the NHS. It's a joint people assessment. So I'm happy to hand over to Andrew if he has anything to add.
No, I'm really just to thank the public health team for the work they did in preparing this report. It's incredibly helpful, and I think it evidences the joint working that we can do together. It's given us great insight into the ongoing need of the community in North Kensington, and we're going to be using it as a way of planning our healthcare delivery over the next few years as well. I think it's an indication of our attempt by the NHS to maintain transparency around how we are assessing the services that we're giving and how we're monitoring the impact of the fire going forward as well. So a big thank you to everyone, and happy to take any questions with the public health team.
Thank you very much. I was just going to start by saying at this point, 7 years on, our insights and strategy, I believe, should be influenced by the outcomes of people's health since the fire in the Grandpark community and wider North Kensington. And I was just wondering, do we have this data from the NHS, and has it formed part of the development of this future service?
So yes, indeed. So there is a database which is owned by the NHS, and we work within that database in terms of processing, analysing, understanding data on the population's health, and that includes data around GP visits, hospital visits, and diagnoses for long-term conditions, and how those are monitored over that period of time. We have a particular population health monitoring programme that looks to measure over 100 of those particular conditions and indicators, and have clinical conversations with local GPs and specialists at the hospital with regard to any variation that we see. So we're constantly scrutinising each quarter that data for any variation that we identify, and part of that conversation with the clinical teams to look to understand the reasons for that variation. Sometimes there will be a change in prescribing protocol that might impact on that. Sometimes there might be changes like diagnostic interventions that we've just talked about that can look like an increase, but then when you look into some more detail, it seems to have changed the system that's caused that. So that is a very important tool and a resource to continue with. What we've also done for the first time, particularly in a move to more openness and transparency, is to look to collate the data from the wider health monitoring services that are in place. So that includes the enhanced GP health checks that local people can access on an annual basis. It includes the respiratory clinic, it includes a special paediatric clinic, and it includes a toxicology service. And alongside that, the wider mental and emotional wellbeing support services. So this JSNA has given us an opportunity to bring that data together for the first time, to look at it as a system, and to basically draw inferences based on that data. Also, in terms of the voice of local people, what local people have been asking for is to understand what health monitoring has been taking place and to see the outputs of that health monitoring. So I'm hoping this document takes us a step closer to that, but I do recognise there's a lot more work we need to do to make that information much more accessible and transparent on an ongoing basis.
That's up to that. Thanks, Anna. We can completely understand that the data, clinical data, may not provide the full richer picture of the needs that are on the ground. So we are very much focusing on the community insight, and we have concluded our 5-year North Kensington Health and Wellbeing Survey as well. But we continue to sort of provide opportunities and engage with the local communities, the wives and bereaved, in partnership, obviously, to ensure that their voices and needs and their challenges and barriers are incorporated, and sort of put aside the data to really bring light to what numbers actually mean to us. But at the same time, I think one of the things that we have recognized as a process is that we're very focused on the data that is held by the council and the data that is held by the NHS partners. But there's a lot of community-led activity that has also taken place in North Kensington. And probably those, let's say mutual aid groups, or those, emerging grassroots communities that, came out after the tragedy and still continue to support, they may have different levels of data which are not sort of married into that wider system. So we very much recognize that as a way of improvement and building upon that. How do we support those voluntary and community organizations to also bring together that richness and bring up a wider picture as well?
So have you used a combination of all of that data together to inform this.
We have tried to, but
Yeah.
we want to improve on how we build that communication programs.
And then just quickly, the one thing I noticed was on the sort of intro of this paper for the appendix, you note in the intro in 1.2 that residents feel there is a need for more work to be done, and with focus on clear ownership, accountability, and service availability. I know from OSC how much work and engagement's gone into this, so I just want to understand what you meant by that comment. So what are they feeling that in terms of the sort of more work to do there? Is it to do with the engagement or?
I think there's a difference between what we call as community opinion and genuine co-production. And when we talk about community-led recovery, there is around how do we really give that power to the residents to really define what needs and what services will support their emerging challenges as well. How we have engaged also because of the timelines and because 7 years on, it was a very new landscape for us to work as a system as well. So we have primarily relied on the international evidence that has existed, but also the community opinion. And we've also sort of understood that when we hear and listen to the community in a more genuine way, there's always a risk of that skewed imbalance where some, more usual suspects will sort of form a representative view, and there are some very, very important voices which remain hidden or unlistened to. So that's where it is, that how do we really create that balance in terms of funds?
Yeah, I just want to support what Muskan said. But also, I think, Chair, it's not just this particular JSN. I know that's the policy of this paper, it's across the whole council as well. So we have reviewed the dedicated service. We're reviewing our voluntary and service, our voluntary and community sector grants as well, where people felt they weren't getting the same thing. Coming to the leadership team on Wednesday night is our education piece and youth club support, how that kind of works, because we did get a lot of views and feedback to say, yes, some things your council is doing right, but some things also is not doing right. So that's what everyone in this room is here to do, to ensure that things that aren't particularly working well is referred to and referenced and changed. And this is what the new refreshed JSNA does. And as you'll see, and as you know, from that we've taken on board, instead of just having kind of one set of recommendations that public body take forward, we've kind of split it into 3 separate categories with 6 or 7 recommendations, each depending on what it is, bereaved survivors, North Kent community, and the wider community as a whole, which I think is a really much better approach to that as well, and how we kind of do that too. And I think, as mentioned, we've done that as well with the dedicated service, instead of just putting everyone kind of across the same brush, focusing on different people's issues and concerns, which the JSNA does attempt to do as well. Again, these are just recommendations, so we really support the committee's views and opinions on that as well. And just for next steps, this comes to the Health and Wellbeing Board next Thursday, which is the final sign off. And as you know, the Health and Wellbeing Board is a statutory body where everyone comes together to look at healthcare across the borough, or in our case, Westminster as well. But there's still opportunity for people to have their say on what they think may be working or not working right as well. And I think the team here and Anna, led by Anna, is really open to that as well. And if anyone has any opinions, Phil, we won't be opposed to them coming forward even at this stage.
Thank you.
Thank you, Chair. Very interesting report. I'm just quite concerned about what I'm seeing on the ground. There are a lot of people that are not getting the help. Some are not getting the help that they need in order to, come out of the tragedy, the COVID and the cost of living crisis, which you mentioned at the health inequality in Notting there. I'm just quite concerned. What will you be doing for those with the 19% Black ethnic minority group? What cultural provisions will be put aside to help them, and how will that be shaped? Because they are in need of serious intervention. Now, I don't know how you're going to be doing this, but I think they need to be around the table, or I think we need to have some sort of session to get them to come in and talk and to explain their own experience, so that you'll have a broader picture. As you say, it's not all hat fits all, but I think if we can make an attempt to actually look into other areas where we can help these people, on a cultural sensitive basis.
I mean, I think that's hugely important. And I think although we publish now, this work isn't finished and this work is ongoing, and our commitment to monitoring the health and well-being of the population is ongoing. Culturally competent services has been a key theme with every group we've talked to. Andrew might want to talk in a minute about some of the work the NHS have done in that space around culturally competent training, etc. And certainly it's a conversation that we've had back at FIG and back through the North Kensington recovery groups, etc. About how do we make sure those services are accessible? And some of the types of examples we've given is people who want to access counselling services in their own language. And although we have that on offer, one might have to wait a bit longer for that. So that in a sense is inequality as well, which longer term. We need to be much more on the front foot and thinking from stage one, do we know our population? Do we understand who's in our population? And are the services that we're commissioning and shaping able to respond to the needs of that population rather than playing catch up?
Absolutely. My concern is, how do you measure someone who's experiencing trauma from Grenfell from another mental health, and problem? How do you access certain service based on certain criteria? And I think that needs to be looked into instead of being pushed all over the area, not knowing where you belong and need to actually start an intervention. We need to identify how, when, what's happening to this individual. Is it depression? Is it PTSD? Where is the first point of pause? How are we going to challenge and try and solve their problem instead of sending them from pillar to post, and then the next 6 months they end up back to square one with no form of help? And this is very frustrating because I see it. Not that the help is not there, but there should be a pathway to getting better and service. It's not everyone that is commissioned to do certain things, but at least they'll be signposted and get the right help they need.
Shall we see if, Andrew, do you have anything you want to add to this discussion?
Yeah, I mean, the point around understanding cultural competency is something we learned very early on after the disaster. So we have developed a whole training package, which is now nationally recognised as kind of gold standard for teaching everyone who works with the community around the importance of cultural understanding and working and behaving in that way. So that is something we've learned, and hopefully my experience is that most people have gone through that training and benefited from it. There is no wrong port of entry into the care services for anyone who feels affected by the disaster. And we have set up various services, whether that's with the dedicated service with CNWL, which people can buy, which people can access, or through their GPs. And we have made sure that GPs are given the resources to have extra long appointments with patients to make sure they have the full conversation, exploring all the areas that you hinted at there, whether that's mental health or physical health or anxieties, other anxieties about their future health. So we have made sure there's extra resource in the GP offer in North Kensington, and that's been there for several years. We're in the process of developing further enhanced checks for people that might have been exposed to much more risk from the smoke and the fire. And these are a package of tests that include a gamut of tests for lots of things that we think might be something that happens after the fire. And the GPs themselves have access to referring any concerned patients, any concerns that they may have or the patients may have about their health, into the paediatric surveillance service and the adult respiratory service too. So we really do have, and I think we've shared it with you before, we have a wide range of services available. We're currently reviewing them and making sure that they're appropriate and available and convenient for patients, and we will be redesigning those with patient and community engagements as well. But and I'm very aware that not everyone is aware of these services. It's very hard to understand what more we can do, and we've been making it known in mosques, in schools, in community centres. We go and meet with residential groups. We go and meet with Survivor and other groups as well. And I know that many of the councillors signpost people into the services as well. So hopefully we've made it as accessible and as appropriate as possible.
I think, though, Andrew, if I may, evidently we do have a large proportion of the North Kensington community whose first or second language is Arabic, and that is quite a large part of the community up there, especially Moroccan. But just given Portia's interest, especially in the Afro-Caribbean community, have we done anything specifically to help them, considering, you know, they've been in the that community's been in borough for decades, and how the cultural appropriation element of this service can help them?
For example, when Grenfell happened, we had Estia, they were in rainings. Now I think they're at risk. So we need to understand areas where people are comfortable, where they would like to go, where they feel relaxed, where they can talk to someone that looks like them, speak like them, trust them. Because as you know, trust is a big issue since Grenfell, and trauma is not very nice when you go through it.
Oh, Andrew, I think you're on mute.
Yeah, sorry, I completely understand that. And one of the other things that we use are a wide range of voluntary sector. We sponsor a large work of voluntary sector work, which is supposed to help and get into communities and both help identify problems and signpost to services, but also help with people's recovery too. And I think we had a presentation at the last scrutiny committee of some of the voluntary work that was doing that. So completely get that there's a wide range of communities that we need to access and offer this service to out there. I think we're doing our best, but we can probably always improve that.
Thank you.
Thank you.
I have a question about children. So some of these children were really, really young 10 years ago. Obviously now they are adolescent or young adults. So adolescence on its own brings its own challenge in terms of mental health and some anxiety, especially after closures of schools. How are they treated? Because obviously they're going through a natural development phases, but with the extra burden of what they have gone through, and some of them might not even have a full memory of the events if they were so young. So how are they treated in this whole process? Because it adds an extra challenge.
I'm happy to speak to you. So in regards to children and young people, so the first point of call would be via the special services, so paediatrics would be the first point of call. That would be via Imperial Trust. They'll be getting the usual checks in terms of respiratory reviews. Following on from that, there is also some support that's available within schools. So that would be some talking therapies and counselling services. With a lot of community engagement, we had a lot of interest around children and young people, how they are actually transitioning from younger, early ages to adolescence and to older ages. So I think there's definitely scope for us to do a bit more research into that. Public Health are also looking to do a health and wellbeing survey for schools. We have also looked into the fact that some people that have been impacted by Grenfell may not be in school due to whatever reason that might be. Also some issues around adultification that's happened as part of the process of Grenfell, the impact of that alongside the cost of living crisis and COVID. So we're also looking into additional supports and how we can support that. But I think we definitely need to, and Jason has definitely kind of highlighted that in terms of that additional support for children and young people. The Grenfell Health and Wellbeing Service, which is a lot on the NHS, is quite good in terms of the transition from children to young people. There's a key focus around 18 to 24 and how you transition into that. It's a very seamless transition, and having the ability to kind of replicate that throughout the rest of the other services would be something that we should be looking into. Thank you.
I was going to say, councillor, if you like. Absolutely right as well, but also I think from an overall strategic part of the council too. So we work really closely with Children's Services as well. So we've got something like the Grenfell Education Fund. We're working in conjunction with this too. The dedicated service and the graphical support team track children, especially as they go, like you say, it's been 7 years now, but they're in secondary school or gone to university or from primary school into secondary school. We kind of not just tracked obviously their health records, but also their educational attainment as well. I think it was really important. It's obviously their health is just as important, but also how they're going ahead in their education. And the team does that the best way we can and provides support for that too. But also what we've got from schools, especially not just from children who are going to survivors of wider North Kensington community, because we shouldn't forget, I don't think we'll ever forget, but we had 18 children die in the tower. Obviously, they had so many friends and so many relations in the community as well, and that's a tragedy that will stay with these young people for the rest of their lives. I mean, that's something that we need to help them as much as possible with. But with that as well, we are very conscious that that can have a traumatic impact on them too. So in the report as well, we've got a lot of health and well-being, a lot of mental health support as well. So that is anything too. From the council's COVID recovery fund, there's also a big investment by the council on that into mental health support too, directly through the schools or directly through healthcare colleagues as well. So it's not it's obviously JSNA is really important in order to see what we can do in the next few years, but there are other elements as well that aren't necessarily included in the JSNA that has an impact on children's development as well.
Right.
Do you want Roberta to go first? I'm not a legitimate member of the committee.
Just perhaps if you expand, thank you very much, Madam Chairman. Expand very briefly, but we're talking about disseminating the recommendations and that the work's not stopping here. Could you talk about perhaps what you're going to do going forward to make sure that those public bodies and the wider community, a more holistic approach, takes in all of it into account, and also what we could be doing as a local authority to make sure that the recommendations are acted upon and followed through?
So for
Sorry, I'm just trying to. Sorry, colleagues, I've got a bit of a cold. I'm just asking for a glass of water. I'm sorry.
So for us in the local authority, obviously the JSNA is informing the work of the future growth fund, but wider than that, the recommendations I think are for every aspect of the work that we do across the local authority. So we're having conversations across the council with teams about this document, about the recommendations within this document. Alongside that, as Councillor Rendell has said, we go to Health and Wellbeing Board on the 18th. Part of that conversation at Health and Wellbeing Board will be how the system can take forward the recommendations of the JSNA. We started conversations around the various fora that exist to say which recommendations can fit with which fora and which potential group could take oversight of those systems-wide recommendations. And we're looking at how we review the terms of references of those groups to ensure that responding to the recommendations gets built into the terms of reference of those groups. We're also very keen from a communications perspective to have an ongoing conversation with the community around the recommendations here. So as well as making some accessible sort of short reports about documents that we'll be looking to share quite widely, we'll be looking to have ongoing conversations with community groups, with community organisations. We can start to think how we can use libraries as a particular hub around health and wellbeing needs, and particularly population health monitoring and information around that. We've been reviewing our website and looking at how we can make data more accessible on our website. We're working with NHS colleagues to develop a series of short video clips because we know for many people they're more accessible than the written word. So we'll be working with each of the clinics and our local GPs to do short video clips around the services that are available and what the data that we have from monitoring of those services says about health and wellbeing so far within our population. So there's quite an ongoing communication piece that falls out of this JSNA. And I would say JSNAs are iterative. So we will be looking to add to this JSNA as we move forward. So as we have conversations in the community and things are identified, for example, we had our Combating Drugs Partnership meeting today, one of my conversations with partners, as an aside in that meeting, was could we look to understand a little bit more the impact of Grenfell around substance misuse and alcohol. And so that's an area that I'm really keen to take forward as a sort of a subsidiary to this piece of work, because although we touched on it within this, we didn't deep dive into it. So there will be areas that we will want to look at in more detail, and we will continue to do that work. And as that information becomes available, to share it not just with the system, but our commitment is very much to sharing it with the community as well in more accessible ways.
And just as a very, very quick follow-up. Will you be the system that you're sharing with? Obviously, it's brilliant that you continue to work more, that will be ongoing. But will you be going back to the system and the various bodies for, say, for example, in a year's time, to see how those things are bedded in and whether they're working, whether they need to change, or how they or whether they are actually being implemented as you would have foreseen them?
Yeah, so the Health and Wellbeing Board owns the Drug Strategic Needs Assessment. Drug Strategic Needs Assessment is the statutory responsibility of the Health and Wellbeing Board. So part of what the Health and Wellbeing Board will do is take oversight of these recommendations too, and their delivery as part of the system. So I see us regularly reporting back to the Health and Wellbeing Board on progress.
Thank you very much.
Thank you. I just wanted to commend the consultation and also the partnership working. It's great to have 3 colleagues from the NHS with us tonight. And you can clearly, I think you can clearly hear the voice of residents in this report. My one concern is that some of the recommendations, and certainly the splitting into 3 groups, is also clearly a result of having listened to residents, and is a very sensible way to go forward. My only concern is that some of the recommendations are looking a bit woolly to me. So if I take, the first one, we must become, service infrastructure must become more robust to accommodate each individual and their needs, and then barriers to access must be addressed and reduced. That's fine, but they speak to me about perhaps there's not enough communication out there about what is on offer in the community. And then I worry about how we're going to monitor and implement those aspirations in the JSNA. Now, the Health and Wellbeing Board obviously is going to be the body accompanying that, but I suppose I'm saying I don't really envy their task based on these recommendations. Would you agree that there is a danger that they're a bit woolly, and how are you going to help the Health and Wellbeing Board to kind of turn that into real improvements and real effect for residents?
So I very much accept that. And the recommendations, in a way, some of those recommendations have been very much written for the system, so that they can apply to GP world, they can apply to a hospital world, they can also apply to adults and children, social care, and sort of the wider councils. So part of what we will be looking to do through those groups is to develop implementation plans that come out of this that will be a bit more specific about how they will be met.
Do you want to know very much on the same point that even at the Health and Wellbeing Board next week, we will be sort of asking the partners to think about the commitments that they can make based on these recommendations, which they can take back to their agencies and organizations and sort of deliver that. And as part of our ongoing commitment, not just to monitor the population health, but also engage with communities, we'll be asking the communities to hold us accountable on how have we achieved those. So, what you mentioned as a tool, which are more intangible things about cultural working and, how people feel accepted. This is the qualitative experience of people. And that's where we want to continue ongoing community engagement to see how we are performing on those elements.
I suppose that's true. I was just thinking that although the Health and Wellbeing Board, we can't kind of double do the work. The Health and Wellbeing Board is responsible for doing this work. But at some point, maybe we want to say to them that we have concerns about how this is made concrete, and whilst fully trusting them to do it, that looks like it could be a danger of making this as effective as it should be as a piece.
No, I completely agree with Mary's point, and I know Sarah has actually written the same question.
Oh, fine. Okay.
That's what Mary had brought up, so that's
Chair, I think that's a really good a really good suggestion. And again, the purpose of today, of course, is to scrutinise the report, and I think it's obviously take guidance from government's colleagues, and turn them your gift to write a letter to the Health and Wellbeing Board to say the committee has scrutinised this, has some questions, and we can put that next week to the ITS, to voluntary and community partners that work with us, the council to if you want to do that, that's I think that a mechanism that is certainly sort of again because we're still open for comments and views on the case.
Thank you.
And just lastly, the doing is going to be done by the people in this room, presenting on the JSNA and also the voluntary and community sector partners. So we have very strong commitment to turn these recommendations into genuine actions. So I think the accountability goes both ways. So we'll be very much keeping our foot onto that accelerator there.
Absolutely, but if we don't know where, when these services are implemented or a roadmap to all the services, how will we be able to have an input service delivery process?
A lot of the work sort of depends on the relationships that we have with the partners, and over the past 18 months and over the past 7 years as well, that we have started to work more collaboratively across the system. The aspiration is to continue strengthening that and how we work together, challenge each other, provide us each with data, but also bring in and centralize the community voice there is how we continue to adapt and shape how we work. But I completely agree that there would be an element of that roadmap of what the future services look like. So after the funding of our services ends in March next year, we are already sort of thinking around how we engage with the communities to understand what are their needs and how the services will be shaped around the needs.
So when will this journey be implemented?
So it's ongoing, it's ongoing. We are continuing to speak with the communities. We are continuing to sort of take findings from the communities inside. We are speaking with the patients who are already patients and service users who are already part of existing services to see what their future needs are.
Is it possible to find out who your engagement officers are?
Yeah,
absolutely. You can add a list.
Absolutely.
Thank you.
Okay.
And also a lot of it has been very much done by colleagues around the table tonight. And I would also like to say thank you to the North Kensington councillors who we've met with several times over the last 18 months, and we're keen to continue that relationship as well.
Absolutely. I'm not saying you're not doing good work. What my concern is those that are falling through the net.
Yeah.
Because I've seen it on a daily basis. That's my only concern, and how we're going to get those, from the deprived areas, those to come forward, those to understand that, look, this is what's going on with me. This is the psychology of what's going on with me. And helping them to understand and going to get help. Because it will lead from one stage to another, and none of us will be safe on the streets.
Yeah.
I'm just going to ask you a couple more questions, and then also if anyone on the screen wants to come in with some final points. You note that members of the community, a lot of them were not aware of the enhanced health check offer. So just an understanding how I know we've touched on this before and Andrew spoke about it, how we do plan to ensure this is communicated to people better. And then Anne has written a question which I'm going to read out, which she's concerned these health checks were very likely performed in short appointments. Notes that the checks sound very positive, but what is actually done above and beyond the health checks that are offered normally and usually is their blood work taken, and we differentiate so the normal checkup with this checkup. So 2 questions there for you.
So I think possibly they're best answered by our GP colleagues online. Hopefully,
Yes. So the health checks are often an opportunity to explore patients' concerns and also to direct questions around things that might have a real impact. It's also an opportunity to review patients who've got long-term conditions to see if there's been any impact of the disaster on those things like diabetes or COPD. There is a suggestion that there's a minimum set of tests that are offered. Every patient, though, is an individual, and we don't want anyone to feel forced into having any tests done which they don't feel are necessary. However, there is access to any test that the NHS has available. So if we have concerns about any lung conditions, then we can organise chest x-rays or refer on to the adult respiratory team who have a state-of-the-art CT scanner and other things that they are using to monitor North Kensington residents affected by the fire. Likewise, with any paediatric concerns, we've got the secondary care team led by Mando, who have access to the whole range of tests and investigations that are available at the hospital. So although the initial test may seem as though it's only offering a few investigations, there is access to every test that our acute trusts have available too, and patients are prioritised into those because they're flagged as North Kensington survivors or residents.
Okay. And just on the second point, which was the fact that the numbers and figures, particularly for children and young people, on the uptake of these checks is pretty low. How we can ensure that we are getting more people to at least know that they are, or how they can access them.
Yeah, so we have lots of issues around uptake of these appointments, and then we have very high rates of DNA, that people not attending appointments when they're offered. So we do have an issue, I think, about the value and the appropriateness of some of these tests, or the appropriateness that the community feels that they are. So that's part of the work we're doing around the redesign of the services now, to make sure that they're more relevant and more appropriate. But we will keep them open for as long as, because it might well be that people's appetite for getting investigations varies from time to time, and we've found that with certain groups, that sometimes they are very keen to find out what's going on, and other times they kind of want to ignore it for a while and move on to other things. But the access to these tests will stay. I guess we will continue working. We have a specialist engagement team which we will be keeping, which work with communities about how we get these messages out there. And I guess we will just keep working on that to see what we can do. We will be reworking with the new enhanced check for residents who were in the fire and experience most of the smoke in the latter stages. We will be relaunching that as an enhanced check in the next few months, hopefully. And so that will be an opportunity to remind the rest of the community about the other tests that are available too.
Thank you very much, Andrew. Any final? Just move on to some recommendations. Is the committee happy to recommend to the lead member to ensure there is a clear plan for implementation of the recommendations in the JSNA, with updates on improved health outcomes, which should be communicated to the bereaved and survivors and the local community? And also, Josh, your idea of what we just spoke about in terms
Yes,
of
I'm chairing the Health Wellbeing Board next Thursday. So,
right.
yes, I'm happy to accept. So if the committee's happy to read that recommendation, I suggest that we, on behalf of you, Councillor Knight, you might say letter to the Health Wellbeing Board, which will put to public debate and circulate ahead of the meeting, and it can help to form the discussion.
I also like the engagement teams.
Yes. Sorry, I just have that on my list too. Thank you all so much for coming and speaking to us.
Thank you.
Moving on to agenda item 6, RBKG immunisation programmes. This report is provided to allow the committee to scrutinise progress with the immunisation programme in the borough and seek assurance about the delivery and uptake of immunisations. This follows a report from this committee on the 29th of June 2023, where members of the select committee discussed a report on childhood immunisations in the borough provided by the NHS. We're joined in person by colleagues from the council and online by colleagues from NHS and West London ICP and the council. Could you introduce yourselves? I don't know if anyone wants to speak to the report.
So I think. So I was going to come in. I'm Simon Hope. I'm the Borough Director from West London. I'm not sure. Anna, sorry, Anna. Were you going to come in there and kick us off?
So I was just going to go through the order we agreed, Simon, but let me leave that to you to do. So over to you.
Okay, thanks. I think we were going to start with Susan from NHSE, who's prepared much of the report, and then to provide an overview, then go to Kevin from North West London to give the ICB perspective, and then drill down locally, hearing from Anna as the DPH, and then going to Dr. Katz as a local GP on the ground. So if everybody's happy with that, Susan, are you able to come in? I know you might be on a train. If you are, then we will go to Kevin instead. If you want to come in, then now's the opportunity. No? Okay, thank you. Kevin, do you want to kick us off as we discussed, please?
Kevin Driscoll from North West London ICB. I head up vaccinations and immunisations for the ICB. I just wanted to, hopefully colleagues have had an opportunity to read through the report, so I don't intend to go through it in any great detail, because there's a lot of detail in there, and I hope colleagues will spend some time looking at that detail. But I just wanted to really reiterate that our sort of focus of attention really is on the 20% of our populations that are really not coming forward for vaccinations, and that 20%, I mean, broadly, it is 20% across the boroughs, including West London. I mean, in some areas it's slightly more than that, and in other areas it's slightly less, but broadly it's around 20% of our populations that are not coming forward for routine and scheduled vaccinations. And through our engagement work and through feedback and through discussing and having those conversations with our local communities, we know we've got 3 or 4 areas where that have an impact on that 20%, if you like. One of those is really around convenience and accessibility. You know, can parents, you know, get a clinic appointment for their child to get their child vaccinated? Is it at a convenient time, etc.? We've also got a proportion of that 20% who are ambivalent for a number of reasons, whether that's through, you know, deep-seated belief system, ideological reasons for not coming forward. We've got that group. We also have, you know, a significant proportion of that 20% who are acting on misinformation. So colleagues will be familiar with the Andrew Wakefield discredited link between autism and the MMR vaccine in the mid-90s, and that's still that information is still floating around, and we do have some of our communities and individuals who still make that link between the MMR vaccine and autism. So it's about, you know, working with those individuals and those communities to address that misinformation. And then we do have a very, as I say, a very small segment of that 20%, maybe around 2% or so, who are very highly unlikely to come forward, as I say, because of their religion or ideological reasons. So we have to understand where we need to direct our resources, and to understand how we can have most impact. Now, in terms of what we've done in terms of understanding some of those reasons, is we've developed a North West London plan, which we are helping boroughs to implement, and this is the case in West London as well. And the plan, in essence, has 3 focused areas of delivery. One is around improving capacity, so extending access through extended access hubs. We've got a roving team that provides additional clinics in boroughs in North West London, including in West London. We also have, part of the plan is increasing access, so providing opportunistic vaccinations. And colleagues may be familiar with what we're doing around the community pharmacy Pathfinder sites. And in each borough, including in West London, we're looking to get at least 2 community pharmacy sites set up to be able to offer the MMR vaccination to parents through, you know, the offer through the community pharmacy sites, and that would also include those pharmacy sites staying open later into the evening as well, to increase that access. And then the other key thing we're doing in terms of the plan is really stimulating demand for vaccinations. We know, as I've just mentioned, in terms of some of the hesitancy that is in within some of our communities. We have a program underway at the moment called Community Engagement First, and that is being led by the North West London roving team. Colleagues will be familiar with the roving team. They go off and do clinics and pop-ups and so on and so forth. Now, what we have is we've developed a program where we're working with grassroots organisations, so community organisations, and so far we've got a network of 20 of those, 4 of which are in West London. And as part of that process, we have offered small amounts of funding, up to 5,000 for those organisations to work very closely with the North West London roving team to facilitate access, if you like, to some of those communities. And often those communities have a lot of mistrust with the NHS and healthcare organisations and public bodies more generally. So that is really about having that first contact and developing that contact in terms of a dialogue, communication, discussion. Once we, have developed those relationships, then we often then run clinics in those communities. So it isn't turning up with the clinicians and then running clinics. The first contact is about having conversation, understanding concerns, and it may well be that over a period of time, the roving team and some of those clinicians do go back and answer questions, as I say, build that trust over a prolonged period of time. So that's the approach we're using across North West London. As I say, understanding that sometimes it's around convenience, accessibility, sometimes it's around having greater access and increasing that access through opportunistic interactions, and then also, as I say, stimulating demand through having conversations with our local communities, and also that's also supported by a fairly substantial communication plan as well that we've developed in North West London. And overseeing all of that, we're just about to set up a task and finish group in North West London where we're going to have some of our key partners involved, including from public health and local authority, and that group will oversee the work of the plan that I've just outlined, will provide challenge, but what it will also do is actually look at what other areas are doing in terms of evidence-based practice and best practice principles, and then start to understand how we can use some of those principles in terms of the work we're doing in North West London and obviously in West London as well. So as a sort of brief canter through the
Thank you very much, Kevin. I was just asking Naomi, could you just speak on from a GP level? And also the one thing I'm just going to note quickly to see if, before we go to questions from the committee, is one thing I really felt was missing from this report, which I did ask for, with diagnostics, because we've obviously had an outbreak in North Kensington, and that was an area of concern for me that I really wanted to understand how we were reacting to that. And there's not anything in this report.
Okay,
So
I'll
if
go
anyone
through that. I'm
could, that'd
sorry.
be great.
Yeah, okay, so I'm going to go through very, very clearly what we did when this outbreak happened. And I have to just tell you, we did learn from an outbreak that happened over Christmas weekend. So this was a very much a learned experience from what happened at Christmas. So first of all, we looked in system 1, which is our computer system, and we looked at every child initially just in Barby School that was not double vaccinated. Not just the kids that were in Barby School, but we took up to the age of 13, so kids that had been in Barby School, right? Every single one of them was put into a search, and if they had not been double vaccinated, they had a call, but I'm going to now explain how that then call happened. We then extended that and we looked at all the schools closest to Barby School, because we started seeing kids with symptoms. We couldn't necessarily get the results quickly, but we had them from other schools. So then we looked at all of those schools. We ended up, I think, with a list of 14 or 15 primary schools of all children under the age of 13 that hadn't had 2 vaccines. So we looked at people that were half vaccinated as well as 2 vaccinated. Right. Then every single child, we then, I shouldn't say this, probably stalked, but we called their parents on multiple occasions. So we did a first call from the doctor. That phone call, if they didn't answer, they got an SMS and an email saying, we need to contact you. The doctor needs to talk to you, right? Normally, if the doctor needs to talk to you, we don't always say it's about vaccine, because they might not call back if they think we're going to do that. The doctor needs to talk to you. Then we basically, most children were called 5 times until we got hold of them. Most of them we got hold of the parents, okay? Some had been vaccinated. A small percentage, about 5 to 7% in total, had been vaccinated, okay? Their vaccines were either done abroad or they had been done privately, and they were not recorded properly within our system. Right, so that was good news. Some have been vaccinated out of schedule, And then a lot of parents didn't want the vaccine. Now, some parents, when you call them and say, there's a measles outbreak in your school, but if your child isn't vaccinated, it might need to be out of school for 2 weeks. Post-COVID experiences, these parents were willing to vaccinate it. Again, a small percentage, but we did get vaccines done, and we will get all those figures once this whole process is over, because it's actually been much more difficult to get than we'd wanted, okay? So some were vaccinated. We also, in addition, did patient education in the school. We also did a big, huge children's event over that half term, because I don't know if you remember, it happened just before half term, and then immediately afterwards was kind of the week of half term, and we did on the Friday a massive children's event, and I think we had about 150 kids who came in and out of various different situations, and every single one of them would check for their vaccine status with their parents offered. There were lots of parents that didn't want it. And I'll give you one example of a parent that said to me, but my child's had the measles, she doesn't need the vaccine. I said, well, you don't know your child's had the measles. Definitely. I'm not giving them the vaccine unless you do me a blood test to show me that she hasn't got the vaccine. So I said, okay, I'll give you a blood test, but as long as you promise me that you'll do the vaccine if she isn't immunised, right? Obviously, the child wasn't immune. And the parents still didn't want to do it. So we're dealing with a huge kind of force against us. But we did get somewhere in this. And actually, there was some fear in the parents. So we did get a little bit closer. But we did understand how much you have to push to do this. OK, now, we also need to tell you is that part of the reason that the figures are really quite poor for Kensington and Chelsea or West London is actually because they're not done in the right time frames. And that is because actually the West London practices have taken on a lot of the asylum seeker hotels. And a lot of these patients came, they were all vaccinated. It's just not within the right time frame because they didn't come into the England at the right time. So I just want to give some of that information. And if you look, even these hotels are actually located in Westminster, but the patients have been registered at West London practices, and they've taken on the majority of this work.
Okay.
Was that clear enough?
Yeah.
That
was definitely a question I was going to have, which is why, in comparison to other North West London boroughs, are we not up to scratch in terms of the figures? And I was going to ask if we were doing anything particularly wrong, but that might answer what you've just asked. Portia.
Yeah, very interesting findings. I was wondering, because I've actually had a few, conversation with parents. What's the time frame for getting your child vaccinated for like mumps, rubella, or MMR? What's the
we'll
time
do it
frame?
any time. We would like it done.
So
we would like it done at 1 year, but we will do it any time.
So 1 year.
1 year and then at 3 years. You come in, you give us an arm, we'll vaccinate your child. Under one, we're more anxious about it. Under one, we are slightly.
No, I'm asking another question. So what if this hasn't happened within this time frame? Would it still have the same effect?
It will still immunise your child. Yes, your child will still be protected.
So if they did it at 10 years old, will that still be effective? 15? So it'll still be.
Give us an arm, we'll do it.
Because based on what I've been told is that they don't think their children is fit and strong enough to have a disease or whatever pumped inside their child when their child is not fully developed. So they would like to wait until the child gets stronger.
But there are lots of people that do say that. And of course, that isn't the guidance. But of course, we will do it if that's what they want. A lot of parents I called, I was quite shocked, actually had autistic children. And so it was part of that they were quite concerned about. But we will do it at any time a parent is willing to do it. It might not count on our figures. So therefore, it'll look worse to you guys. But we don't care. We just want them vaccinated.
A delayed journey is something that is now widely publicized in the US. So delayed vaccination journey is now a way to get some minorities back into vaccination program in the US following COVID, so they would allow that. France is also adopting a delayed journey for some children as well, just to try to mitigate the conversion back. Yeah, post COVID.
Rebecca.
So just on the point of your figures, Mrs. Katz. So is there any data that you collect that shows all of those people who've been vaccinated, that we can see actually the real number, as it were, rather than the sort of the reduced number, to give us a more accurate picture of who has, how many have actually been vaccinated?
So that's obviously business intelligence, and I'm not an IT person, but we have done a lot of work to try and bring that out. But it's actually quite complicated because of the coding issues. Because the people have done elsewhere, if we put it in the system, it doesn't quite work. So we've got it all as attachments to the patient's file. So it's a coding issue, but we are working on trying to resolve that. We did quite a lot of work, but then it proved a little bit wrong, because if you put it in, the computer wants it done on a specific date, and if you put it in the wrong date, then that's that patient's medical record, right? And so then it looks wrong. So we have it as attachments. So, but we will try and get you that data, I'm sure.
That would be great.
I have a question about, sorry, this I'm obviously new to committee. I have a question about the background of this. How many children were actually diagnosed with measles, and how many were hospitalized, and what were the actual symptoms
From the North Kensington
the outbreak? Yeah.
Naomi, do you have those figures in terms of the North Ken? I think they're in the paper.
Sorry if I missed it.
You're on
Is it Barbara Score you're talking about?
Yes.
Yeah.
I think we had 15 confirmed cases and 4
Okay.
hospitalised. Yeah.
Okay.
We'll follow up and get you that, but I think from recollection it was 15 confirmed cases and 4 of those were hospitalised.
I think, Heather, if I'm right, if you look at the London outbreak and the North West London figures as a whole, the percentage of children hospitalised is actually quite large, isn't it? Yeah.
Well, any child being hospitalised is one too many, isn't it? Certainly, but yeah. But I mean,
in the 40% region.
Sorry, I missed that.
Sorry.
Sorry.
So I think there were up to 40% of all the children who contracted measles had been to hospital. So I guess what we're kind of saying in the context of this, measles is a very serious disease.
Yeah.
It's not just a rash.
Absolutely, and that's my question: is that did it help in terms of convincing argument at all, or was it not something parents were ready to hear?
Well, with the school in question, even after we had those confirmed relatively high number of confirmed cases in one school and the number of children hospitalised, when the team went in there, providing the additional capacity, they had very few parents come forward to get their child vaccinated. So, even where you have this high risk, where parents, understand, that there is a risk, we still had only very few parents coming forward to get their child vaccinated in that situation. So it kind of speaks to what and what I guess Naomi is saying as well, in terms of there is some work to be done in terms of winning hearts and minds here. It's not just about laying on additional capacity clinics and doing that. It's doing the work with those communities, understanding the concerns. Yeah.
I've got a couple more questions for you. One being the North West London pharmacy pilot. Have there been any indications so far on any difference that's made ahead of the further pilots that we're going to be having in RBKC?
So we're looking to set 2 up in RBKC, and we're hopefully looking to get those in Westbourne Road and Harrow Road. Obviously this is an opt-in from the community pharmacy side of things, so there's a little bit of work for us to do in terms of taking them through the assurance process and and getting them set up and doing the training and everything else. We would hope, and we're still working towards those Pathfinder sites being up and running at the end of July. So there's a little bit of work in terms of the data. They're using a system called Sonar. We have to get that set up so it reports back to the GP clinical systems, etc. So, but yeah, the intention is to get these Pathfinders up and running by the end of July, and then they will run for a year or so. So the idea is that they will run long enough so we can fully test out whether these are really having impact in terms of creating greater access and additional capacity in those local areas. So yeah.
Thank you. And then on top of that, my next question. Well, I mean, one thing I did want to ask, we've just spoken about schools, but in terms of diagnostics for adults, and given this is headline news at the moment and immunosuppressed pregnant women, what is your testing situation for those who aren't in schools that you're calling up and sort of checking the data of, who might not know they come into contact or might show symptoms?
So the testing regime is really undertaken by the UK Health Security Agency. So obviously measles is a notifiable disease, so any suspected case has to be reported through the UXA process. Sorry, does somebody want to come in? So that process is the testing, and the laboratory testing is undertaken by our UXA colleagues. So they oversee that process. And to be fair, there is a few days turnaround time in terms of those test results coming back. So, but that whole process is overseen by the UK Health Security Agency in terms of testing.
And then just in terms of when we can see the RBKC figures potentially turn around, I know we've spoken about an influx of people who have joined our surgeries, and maybe that's implemented to change the data slightly. But when with the engagement work you're doing and the pilots, do you expect to see some slightly different figures?
Well, we would be hoping to see over the next 3 to 6 months, we would hope to start to see some impact of those schemes, including the local scheme in West London, and Naomi, I think, is leading on that. That's having doing a huge amount of work locally in RBKC. And I think all of those endeavours will start to show up in the data. We would hope, within the next 3 to 6 months. But as I say, the community engagement work we're in it for the long haul. It's having that first contact and then developing those relationships over a period of time. So we don't, unfortunately, we don't just change people's minds, from them having a stance where they do not want to get their child vaccinated into, translating that into a vaccination very quickly. Sometimes these things do take time, and that's what we're intending to do with the community engagement first approach, which is, as I say, developing those relationships and building the trust in those communities.
Thank you. Susan, I think you've got your hand up.
No, it's actually me.
Hi.
Sorry.
Oh.
So I just wanted to, Naomi can probably speak to the diagnostics point, but I just wanted to reiterate the issue about basically vaccination is 97% effective in protecting against measles. So just as healthcare workers and folks who are exposed to measles on a regular basis, we don't do regular testing, that the best vaccination, or the best security really is not a diagnostic, but an actual vaccination. And then those cases where there is a suspected case, there's an oral fluid kit, as Kevin says, which is given by the clinician or by the UK HSA. But often, let's remember, the incubation period for measles can develop quite rapidly. And so, as Kevin said also, folks can become symptomatic quite quickly. And part of the risk with measles is it does spread so quickly. So waiting for diagnostics is not generally a good idea. The other thing I just wanted to mention is the great work of the local authorities, and it's kind of buried in the reports. But if you look at things like HPV and flu and other areas where we have seen increased trends, we do know that there are other vaccinations and there are communities who come forward. So one of the things that we're doing right now in planning, and I really want to thank local authority teams for all the work they're doing in the preparation for the back to school campaign, because for the 5-year-olds entering reception, it's a great opportunity to catch all of those who have missed MMR and other vaccines. So that's something we're planning now with all of the schools across Kensington and Chelsea. Thank you.
Thank you. Naomi, do you have a...
So I just wanted to say what was a bit different is that we've developed some of these schemes differently than we've done previously. So in terms of the community engagement, what I think has been really powerful on these ones, which is why they've been much more popular, not necessarily getting the vaccines, but getting people in and having health advice, has been that we've had lots of GPs who have come in their own time with their own children. So we, have lots of kind of different ages of, we've find GPs with different children ages and they all come along. We've done stuff immediately after Eid to kind of try and support some of the people who had just been fasting over Ramadan, to try and support them and see if they would get their children vaccinated then in that kind of happy period stroke Ramadan finishing. And we've had paediatricians, nurses, everyone available to talk, and we haven't been pushing. All we've done is, can we check your child's vaccine record, and why do you think you haven't done it, and what is it? And then we're all there saying, but look, these are our kids and we've done it. And that's been really quite powerful, and we have had better success based on that, because I think they trust us a little bit more when they see that, you've got lots of doctors there with their own children who are vaccinated. So that's been really positive on this one.
Thank you very much. Does anyone from the committee have any further questions? No, I mean, it's just a comment, building on what was said, and Dr. Katz, was if you look at the report and the RBKC trend, there is definitely an age, I mean, it might just be a picture. There's definitely an age correlation between drop vaccination. And then when you move to the 5-year-old, pit stops, because they work in silos, those vaccinations. So you go and it by blocks of them, I remember, with my own children. And by the time you reach the 5 years block, you do see a much more positive trend. So there's definitely some work to be investigated in terms of delaying the start. It's only a KNC trend, but it's a very obvious one on page 6 in the annex. So it's just a comment that needs to be investigated a bit further.
My answer, I'm Anna Cox from the Public Health team. I totally agree, and we see that in the figures. These are just Q3, but we've seen that recently, that there's a drop off in the figures when vaccinations are measured at 1 year, possibly 2 years. And by the time it gets to the ones that are measured at 5 years, it seems to be holding our own a little bit better. I'm not saying it's increasing, but it's not dropping off like the others. And there's a number of reasons behind that. One is to do with the population turnover that we have. So there are some of it is people are vaccinated, they've just taken a while to get into the system when they've moved GP surgeries. But what we have heard increasingly over the 6 months, both in the engagement sessions that I've done with parent and resident groups, also with our maternity and community champions, and also through our health visitors, that there are increasing numbers of families who are saying, I will, but not yet. Yeah. We're waiting for the children to reach their milestones, and then we'll go and do it. So that all ties in with that picture that you've observed, which we see in the data wider than that snapshot that we see there.
Thank you very much.
Straight on that point. I mean, the thing that stands out is just how much worse we are than everywhere else, and boroughs that have actually a far more diverse population, where you think if religious or communal reasons not to do it, you'd think that you'd be seeing a similar picture or worse. And I'm just wondering, obviously this is just North West London mostly, but even across the whole of London, the numbers are better. I mean, are you seeing that same thing with a 5-year elsewhere? I mean, the bits of London that aren't shown in our data.
I don't know other London boroughs data, the intimacy that I know the RBKC ones. But I do know that it's true. RBKC is amongst the lowest. It moves around a bit when you look at the different vaccinations. RBKC is lower when compared to North West London, but there are other London boroughs who are not doing as well as RBKC.
Right.
So Camden, Islington, Hackney, Haringey, Enfield, for MMR, for example, are all lower than RBKC. So RBKC has an issue, clearly, but we're not alone in that. There is, the patterns vary really widely across London.
And in terms of the delay that you're saying, obviously, in your own systems and bringing that data up, people move. Obviously, the most boroughs in there are central London boroughs that have a much higher churn population than, say, some of the out London boroughs. What work, it might be for the NHS, what work is being done to try and reduce that lag, in effect, to try and give us, because obviously it's very hard for us to look at this. And obviously we've heard, there's attachments on people's files, and there's obviously that lag. It's very hard for us to look at the data and see it as a really a credible or accurate picture of the state of the borough when there are sort of such, I guess, glaring, and it's not obviously nobody's fault, but glaring issues in how we're trying to do things.
Yeah, that's true. I'll hand over to NHS colleagues in a minute, but I'll just add that we've got a borough, so us in Westminster, operational group that is now running its partnership between local authority and NHS partners. And we've got an implementation plan, and one of the things in the implementation plan is trying to look at newly arrived, newly registered families, seeing that as an opportunity. It's an opportunity to update records, but also to have the vaccination conversation. But in terms of, we know from pilots that have been done most recently in West London, but last year in Central London as well, that kind of updating the newly arrived, but also the vaccinated abroad, vaccinated privately, is a real challenge when it comes to data accuracy. But our NHS colleagues are the experts on that.
Yeah, I mean, just to follow on, Anna, I mean, we do see that. I mean, the way the cover data is produced, we get we've only recently just had Q3 published from the cover data, so there's always that time lag in terms of publication. We have a dashboard, so we have a data dashboard for childhood immunisations in North West London, and we pull through unpublished data, so we're not allowed to share that beyond the ICB partners, but we do share that obviously with our local authority and public health colleagues, and that gives us a view of how things are going from the CHIS data, so the Child Health Immunisation Service data, which feeds the cover data once it's been cleansed and published. So we do use that to give us an indication of trends in terms of where we need to understand to target resources, etc. But there's always going to be a lag in terms of data published, and we are sort of we all continue to work with our colleagues in terms of sharing the data that we're able to share. As I say, the dashboard data is something that we've developed over the last year or so to really help us understand where we need to target our resources.
Yeah, I think it's worth saying that West London has had low immunisation rates for a very long time, and it's been a priority for us from PCT days to CCG now to ICB. So we are continuing to look at the reasons why it's happening and keep working hard to do it. We're also doing it around cancer screening. We have similar poor rates in that too. So it is a priority for the place-based partnership and the Health and Wellbeing Board, and something that hopefully we can work together to address, because we have tried to unpick all the various reasons why we might be performing badly without any great impact as it goes just yet.
Also, just to say, Andrew, so we're going to do some work with our CHIS providers, looking at private practices actually. So we can look at those in terms of Central London and Westminster and RBKC to see whether that's having any influence or impact. And we will be working with our CHIS partners over the coming weeks just to understand whether there's any whether that's having an influence in terms of the data. So we'll make sure we feed back to colleagues once we get a better understanding of whether
Thank
that's.
you very much. Susan, do you have a really quick point, just because I'm quite keen to draw this to a close?
Yeah, I wanted again to thank the local authority, because when we talk about data reliability in our data codes, I mean, I think the Barbie school is another good example. When we have accurate, up-to-date class lists and we can rectify that with our vaccination teams, we get a lot of sensitivity sometimes from schools about the sharing of data. And we know that there is a mandate, there's a legal and a contractual mandate for that. But some schools feel quite uncomfortable. Some parents get quite anxious about that. And so even having good data sharing and getting good data is something where we have to work really in partnership closely with our local authorities. But fortunately, I think that has been really helpful on the school side, and we've had really good experiences there, unlike some of the other parts of London where we still have quite big black holes where we just don't have the data on that. But I just wanted to say thank you to the
Thank you. That's really good and encouraging to hear. I'm just going to move to recommendations. After that special planning, is the committee happy to recommend to NHS partners to work further to address vaccine hesitancy and scale up any initiatives which can provide increased immunisation coverage, particularly MMR, to the communities in the borough? And I know that you're providing reports for quarterly to either Josh or us, but that would be great. I'm interested to see if the pilots have a significant difference after they're opened in August. I don't know if anyone else has anything they want to add to recommendations. Okay. Thank you all so much. That was really encouraging to actually speak about it. And Portia.
Yes. Is it possible to have literature, written leaflets in GP surgery readily available with, information on all these measles, mumps, rubella, the impact?
I mean,
and just they're waiting.
Is that come from NHS?
So we should do in our GP practice. I think Naomi will come and comment. Also, a big thank you to our West London GPs who also produce little video clips for us in Arabic as well as in English, which we were able to circulate quite widely on our social media networks, because we know that spoken word is much more attractive to local people than written word as well. Is there anything you'd want to add, Naomi?
There are leaflets everywhere. I think leaflets are absolutely great, but most people need a conversation, if I'm honest. Yeah. But we have it everywhere. Please vaccinate your child. We could even put it on our websites as all of that kind of stuff. But I think that the more information we send, the better. The more times we ask them, the better, because we do get results from that. But yeah, leaflets are definitely in every waiting room. Not necessarily red, definitely there.
Go and double check it and then report back.
Yeah. We can check every waiting room. We've definitely sent them to every GP.
Okay. Thank you. Thank you all so much for coming and talking to us about this. Very encouraging to hear how well everyone's working together. Moving on to agenda item 7, which work programme reports. This report sets out the development of the select committee's work programme, identifying priorities for the release. I can never pronounce that word. Yeah. There is none. Select committee members are recommended to confirm scrutiny priorities for the municipal year as set out in Appendix 1, which will be presented to the Open and Scrutiny Committee on the 17th of July 2024. It needs to develop a detailed work plan setting out reports and items to be scheduled. Meetings on the Adult Social Care and Health Select Committee during 2025. I mean, I think that's you at that. So everyone's happy. I mean, we can have things as the year goes along and things, but then we see James still too.
No, Chad, just say just 2 things quickly. I think it looks like a really good list of priorities. You have to see down the low rates of cancer diagnosis and screening, so that's a policy there, which is good to see. And then one just quick point is There are a couple of items from Orchard's housing in Maxilla where there will be an overlap with the remit of the Housing Communities Committee and the OSC as well. So I think I'll have to work that through with exactly the when and where those particular papers get looked at.
Yeah. And if they're combined with which we do.
Yeah, so there's different options. So we could do part of the work around all people's housing at this committee, and then housing communities can look at sheltered housing, which is much more within the housing remit, or with Maxilla, it may be the same again, or maybe something, because it's so overarching that maybe OSC would want to take a role in. But that's a discussion another time. This is just the main priorities tonight.
Okay.
Yeah.
If you're happy to agree.
Yeah.
That concludes this meeting. Committee, thank you to everyone for your time and attendance.
Thank you. Thank you, Chair.
The vote is one